Well, thank you for joining us today for another episode in this multi-part series called Improving the Continuum of Care. I'm Dr. Larry Patterson with Eye Centers of Tennessee, and with me today are Dr. Mary Ann Murphy, who's an optometrist at Front Range Eye Associates in Colorado, and Douglas Leva, who's an ophthalmologist at Leva Eye Care in New Jersey. The three of us are in very different areas of the country in Colorado, New Jersey, rural Tennessee. But my guess is we all have this in common, and that's staffing shortages now. Everyone I'm talking to, and not just in ophthalmology, not just in medicine, restaurants, everyone's having staffing shortages, and it's just been really tough on us. How are you preparing or training your staff so that they have the tools, the resources that they need to create these really awesome patient experiences? Douglas, start with you.
Well, fortunately, I've been able to retain my staff. My newest employee is about 10 years, so they're all very well trained on the equipment. They're very familiar with form and load it up, and they know how to explain to the patients the purpose of the testing. Uh, I'd like to teach my technicians. My techntechnicians. Uh, are very savvy. I don't just have them do the tests. I have them understand what they're doing.
Mm-hmm.
And so, because when I work out of 4 exam rooms, so I can only be in one exam room at a time. And so when I leave, the patients know my technicians over years, especially the glaucoma patients, because they're in every 3 or 4 months, and so they're going to ask the technician questions that maybe they didn't want to ask me because they didn't want to think they were stupid or something. And so, unfortunately, I've got excellent technicians for a long time, and so they're very experienced. And they also, but since they have been around a long time, they appreciate the improvement in the technologies over time.
Yeah.
When you think about it, we're just laughing about photographs. When I started, they really expected us to draw pictures of the nerve. And even when I estimate cup to this ratios, I may have been a 0.4 mood that day instead of a 0.5 mood. So I really appreciate the fact that we can have very concrete, objective measurements. In fact, I explained to my patients, my father was an ophthalmologist starting in 1957.
Oh, wow.
For him, there was a lot of art. I tell my patients I try to avoid the art of medicine because that means I'm really guessing. I more like the science. We still have to use the art where we use our intuitive sense, and there's times where the computers make mistakes, really, because they're really analyzing the data wrong. So we're not going to be totally replaced, but I rely on science as much as I can, and we're in the era of big data, and that's what Forum is, big data. We're able to analyze the data very efficiently. And of course, now with medicine, like at my local hospital, the doctors were told that they can no longer spend 15 minutes with a patient. They can only spend 11 minutes with a patient. And when they get in the room, they actually time the patients. Fortunately, I'm still an independent physician, so I do things my way. But that's where we're going. You have to be efficient. If you're not efficient, you're going to lose out,
Mary Ann.
Yeah, I would agree. I mean, I've been fortunate to have some tenured staff, 10, 15 years, which is really great. But on top of that, just because of transition, I have some new staff. My newest staff is probably 3 months old. So I think it goes back to, again, what I was saying about equipment selection. And we're looking when we purchase equipment, what training is available? What training is available when you purchase the equipment, but also what's the ongoing training? What's the availability of webinars to be able to train staff so that I don't have to sit down and do it? And frankly, when you are short staffed, the last thing you need is another one of your staff having to stop what they're doing to train somebody else. So, you never want to just sit someone down to a computer. But in this day and age, the young folks are really tech savvy and actually would prefer to learn from some of these computer webinars or things that they can do at home before they even come to the office. So when they get there, the equipment doesn't look so foreign. So we take advantage of a lot of the training that ZEISS and other equipment providers offer online to train our staff. But I'm also with Doug, them understanding why they're doing a test so they can explain it to the patient. They can understand why they're bringing up certain data. And then also, if there's anything that I can train them that I think they can't get elsewhere, that is the listening, the chief complaint listening. And if someone says, obviously, something as simple as, hey, I just moved here from New Jersey and I have glaucoma, they're not going to ask me if we need an OCT. They're going to know that we need an OCT. If someone comes in and they're talking about distorted vision, and they're doing a pinhole and they're doing a refraction and they can't get it clear, they know I'm going to want a MAC OCT. So they learn to listen and be able to decipher those things. Worst case scenario, they do a scan, I have data, and I decide, you know what, I didn't really need that. I can delete it. I cannot charge the patient. Like you, Doug, I'm an independent provider. I love that flexibility where I'm not having to, crunch every dollar and cent. But it's a rare occasion that I get more data than I need. I give my staff that autonomy that if you're hearing something that I'm going to ask for a scan, let me know. And then, of course, for us, on top of all the things that you guys talk about, the retinal evaluations, the glaucoma evaluations, I know that I'm much more efficient in my referrals to my ophthalmology partners, and they are very grateful. They don't need to see a 2040 patient who's just got an epiretinal membrane. And I can watch that just as well as they can. It frees them up to be in surgery, and they love that. Secondarily, though, we use it obviously a ton for specialty contact lenses. So because we have an OCT, because we've had, all the sophisticated equipment that we have, our anterior segment ophthalmologists are much more inclined to refer to us because they know that the data analysis that we can do with a scleral lens over a penetrating keratoplasty. So they know that we're not guessing and we're not just winging it. We're using that same data and have access to the same things they did. But like you said, going back, we had a GDX when they first came out. We've done every kind of perimetry there was. And I remember when we used to print all that stuff out. So as soon as something like Form became available, it's the willingness to adopt that and bring it into practice and your staff to work with it.
Well, you bring up what I was going to actually lead into next, and it's cool having an optometrist and an ophthalmologist on this at the same time. We all, to some degree, do some sort of co-management, whether it's surgical co-management or just working with patients for refractive issues, other medical issues. Doug, how do you foster or nurture the relationships you have with other optometrists and or even other ophthalmologists in the area?
Well, in my area, it's interesting. I have an optometrist that has worked for me. Actually, I hired her as a receptionist. She learned from she actually became then a certified ophthalmic assistant, certified ophthalmic technician, and then we had our first optometry intern. Just boy, I know as much as she does. And so she went back to college, took organic chemistry and the other pre-meds, and she came back after going to Pennsylvania College of Optometry and working for the last 12 years.
That's awesome.
So that was great. Although she functions very independently from me, she managed her own practice, but I'm always there to give her guidance, and she loves having Form. I actually co-manage more cataract surgery and such with actually ophthalmologists than really optometrists, because that's the way it is in our area. There's the optometrists in our area are sort of have entrenched with just ophthalmologists. So that's so unfortunately there isn't much co-management going on in my county, where you guys are a little more rural, and so it's a little different situation. Which is
I would say in Colorado, we are lucky to have really wonderful relationships with our ophthalmology partners. And some of it, I think, is because, they're slammed. They can't be in the surgical suite enough. And so they love saving their time for that. They don't need to be seeing, monitoring an epiretinal membrane, like I said, or monitoring a diabetic. If they know I have OCTA, the patient doesn't need any sort of intervention or any sort of injectable. We spend time learning from them, going to continuing education with them, having open conversations about what specific criteria they're looking for when they want a patient referred, especially with our retina partners. They're really fantastic about communicating that to us. And they know then when the patient gets there, not only have they already seen what their OCTA looks like and know why they're going to see the retinal specialist, they know they're likely to get an injection the day they're there, so that's not a surprise. Then they know they can go back and be followed by the optometrist. So that's a huge part for us. But the additional benefit that we have is, in this day and age with private equity, coming into our state really hard, commercial growing really hard. So much of the productivity and the profitability of those optometrists is driven by the retail component. So they don't really have the time or frankly, the monetary motivation to manage medical. So like you were saying, Doug, you get a lot of ophthalmology referrals. We continue to get a ton of optometry referrals because we're in a private practice, kind of, I would say, a little bit more clinical setting versus a retail setting. And our partners have been really open about knowing they're, sending their patients to us for monitoring versus having to, send them all the way to ophthalmology. And when I say all the way to ophthalmology, it's because we're in a suburb of Denver, and most of the ophthalmologists are located in the city. And you guys know how it is. You have a patient that's 80 years old, and if they have to cross the railroad tracks, it's too far, right? So getting them on a freeway to go downtown and then find parking is a whole nother situation. So I think it's really expanded not just the quality of care, but truly access for so many of our patients, and lets our ophthalmologists their extended reach by teaching us and working with us has been a fantastic synergy.
We've got a very unique situation compared to because we kind of have the whole area to ourselves. In other words, there's three of us who are ophthalmologists. One of them is my son, and we have let's see, 12, 13 optometrists. We're all in the same practice in 9 locations. But being able to have the same EHR in every office, being able to look at what happened when the guy saw him yesterday, being able to see that and being able to all use forum, it's just unbelievable. Let me ask. We danced around this a little bit. We've talked about data. We've talked about forum. We've had forum for 5 or 6 years, and as I mentioned, I just don't know what we would do without it today. And Doug, let me start with you. Tell me how has the data? You mentioned data earlier too. Tell me how this ZEISS forum has supported you. For people maybe not know much about it, how's it impacted your practice?
Well, I practice general ophthalmology, and I've had a forum for about 12 years. I was one of the early adopters, so I have lots of data, and you'll see the longer you have it, the
Mm-hmm.
more useful forum becomes, because it takes a while to get the baseline. In fact, one of the things I learned from, I actually met at one of our ophthalmology meetings the gentleman who developed the first statistical pack, the stat pack for the visual field and
Right.
everything. And he made a good point that you should, when you have an initial patient, you should do the visual field and the OCT two in the first year, because you'll be able to pick up progression a few years earlier than if you wait to develop that baseline. So I've lots of baseline data, also to network all my instruments, because I have, when you think about it, I have the fundus camera,
Mm-hmm.
I have the eyewall master, specular microscope, the OCT, all the topographer. So all that data now is going into one place. I don't know, 5 different, all those companies do allow you to have, let's say, viewing on your computer, but I'm going to open up 5 different applications simultaneously. And this way it's all there. And when I have, all this data, I do use Forum and Glaucoma Workplace, but then again, it's also nice, as you know, when you go to the right, well, let's say, God, let me really investigate a little further. Let me take the first, the OCT from 10 years ago, from 5 years ago, and from today. Let's compare them all side by side, myself, and the same thing. You know what? Let me, it says that there was likely progression in the visual field. Let me do an overview. Let's look at the last 20 visual fields, 1, 2, 3, without flipping pages. I just can't imagine a function without forum, because to analyze all the data would just take forever. Look, I could do it. If I was going to spend an hour with each patient, okay, I could do it. But who has an hour? I love it. I can do the analysis in 20 seconds of what's going on. And then if I need to investigate further. And, one thing we didn't touch on is even with cataract surgery, with the IOL master, I also have Veracity, where I can import I have 3 screens up in my private office, and I have the OWL master on one screen, my my regular data on the other screen and veracity in the third screen, and I can really figure out what IOL is at best for them. And then sometimes I bring the either veracity IOL master and I show it to the patient and share with them, this is why you need to get a toric lens,
Right.
you know, and see the computer's calculating, maybe, and it's sometimes powerful. One eye, look, your right eye doesn't need it, but your left eye, see, it needs this. And I can tell you, look, we have, here's T3, T4, T5, small, medium, and large. You need a large. So would you really want me not to correct that? Don't you want to be able to see better? And, so for me, I just can't even imagine going back to charting and such. In fact, I just had a doctor give me his practice, and I'm cringing. I just got rid of all my paper charts.
Yeah.
And he just called me, telling me, he's going to load up the charts into his pickup truck. I'm like freaking out because I got to deal with charts again. I just got rid of them.
It's funny you say that. In 2012, when we went to electronic medical records, we hated it. And I'm not going to mention the company. We don't use them anymore, but it was terrible. It was miserable for 5 years. We switched to the company we have now. And suddenly, so for people who out there listening to this and you're like, I hate electronic health records, it's because you got the wrong program. There's some really bad ones out there, and there's some really good ones out there. I think all of them could be better. But there are good ones out there. Marianne, your thoughts?
Yeah, I think to your point, same thing. We've had Forum now for about a decade. We've had electronic medical records since 2004. So it's kind of just been the way of life for us. And it is always interesting. We host interns from UC Berkeley, and they come and, we lay out all this datum in Forum, and they just look at it like, why doesn't everybody have this? And my simple question is, I don't know. I think once you see how powerful it is, and like we talked about, the dynamic images and things like the retina workplace and the glaucoma workplace, the value of that over time is critical. And I would just add, I mean, the other reason, and Doug, you alluded to this, but ZEISS plays nice with other vendors, right? I mean, the majority of my equipment is ZEISS equipment, but I have a TopCon, topographer and keratometer. I have a ZEISS IOL master, but I have, a different wide field imager. And everything can be put in one place. And I like that ZEISS continues to play nice. It's an encouragement to, when I'm looking at equipment, bring theirs in because of the way the data reads and obviously having the dynamic data. But I also like that I don't have to go, okay, well, all my ZEISS stuff is here, but then my TopCon stuff is here, and my Marco stuff's over here, and my DGH B scan is over here. Everything's all in one place. And that makes for data management that's a little bit easier, because as you guys know, with all this data comes security issues, cloud storage, volumes of cloud storage, backups, all that stuff. And when it all can be dumped into Forum, having that redundancy in the backup is really critical and frankly, cost saving and efficient over time.
So I'm going to pull this to close. But before I do, I just, starting with you, Doug, do you have any concluding thoughts that maybe we hadn't touched on, or something else you wanted to say?
No, not really. I think we touched on pretty much everything. It's the digital age is upon us, and we have to embrace it.
Any thoughts, Marianne?
The last thing that I would add is, especially I think for optometrists that are contemplating the investment in not just the individual instruments and OCT and IOL master and those types of things, but then the added investment in something like Forum, and they're questioning it. I would just encourage them to understand not only the efficiency it builds, the patient confidence it builds, but really it continues for us to strengthen our relationships with our ophthalmologists. They can feel confident that we're getting the data that we need. I can send them those files. They can incorporate it into their form. They can incorporate it into their data. It can become their baseline. And it's just a different language that we can speak that really helps us continue to provide that continuum of care for our patients. So, I'm seeing people of all ages, but when I need to make that transition to a co-managing ophthalmologist, being able to transition that data and have it go back and forth is really critical in providing high-level patient care.
I'd like to add one more thing is really a very powerful aspect of form is really patient retention. Also, is because if for instance for me, if I have a 20 years of data on a patient, the visual fields, and they see all that, are they really going to go elsewhere?
Yeah.
And let's say, because I don't take a lot of the private insurances, so sometimes I do have patients go elsewhere because of insurance. They come back because they just see that the other offices just don't have the technology. And if we're talking about glaucoma and their vision, and we talked about how patients can sometimes perceive glaucoma with blindness, they're coming back, or they're going to be staying because they know that I'm providing with the best possible care there is.
Well, doctors, I thoroughly enjoyed this. Thank you both for your insights into developing the kind of workflow that's going to support both our patients, our staff, and us as doctors. So thank you very much. And thank you for those of you who are watching. We appreciate your attention and hope this was valuable to everyone.